All right, good afternoon, everyone. We'll go ahead and get started. Thank you all for joining us for Grand Rounds today. For those of you online, thanks for being here with us online. We truly have a special Grand Rounds today, and I'm glad to see many of you in the room and welcoming those joining us virtually as well. A quick reminder on Grand Rounds in the near future. Next Wednesday, October 30th, we're pleased to host the FDA Commissioner, Dr. Rob Califf. Dr. Califf will be here talking about FDA's mission and some of the ways they're interacting with a number of academic institutions across the country to think about that aspect of policy meeting practice. So should be a really great talk. On November the 6th, not to be able to outdo Dr. Califf, we have another star, Dr. Paul Sachs will be here from Infectious Diseases. Dr. Sachs is the Division Chief of Infectious Diseases at the Brigham and Women's Hospital. He will be giving the 2024 Tim Gill Lectureship, which is hosted by the Division of Infectious Diseases. Some of you may have heard of Dr. Sachs. He runs a very famous blog online. He's also the editor for Journal Watch and does a lot of cool things in HIV ID. And is generally a very entertaining speaker. So please join us then. And last but not least, Mentorship Academy is on Monday, November the 4th. I hope to see many of you there. It is completely sold out. We have over 400 folks in a waiting list now. For those of you who have not yet registered, please do get up on the waiting list. We anticipate there may be some openings and better to be on that than not. So there's still time to be on that list. So it is now my pleasure to introduce one of our very own, Dr. Sylk Sotto for Medicine Grand Rounds. Sylk, I'm going to always call you one of our own, no matter where you go. Dr. Sotto has an incredible career. She began her undergraduate studies at the University of Puerto Rico, ultimately graduating from Colorado State University in 1999. She then went on to obtain her MBA in 2003, a master's in professional studies concentrating in healthcare leadership in 2011, and a Doctor of Education in 2017, all from the University of Denver. During her educational pursuits, Dr. Sotto held various professional staff positions, increasing in scope and responsibility from research associate up to serving as the Director of Finance and Administration of our very own Division of Pulmonary Sciences and Critical Care Medicine. I am therefore not surprised to see a lot of pulmonary people in the room today as well. You're a fan club, Dr. Sotto. In 2015, Dr. Sotto joined the team at the Indiana University School of Medicine's Department of Medicine as Vice Chair for Faculty Affairs and Professional Development and Vice Chair for Diversity, Health, Equity, and Inclusion. During her time there, she also served as Co-Director of Workforce Development at the Indiana CTSI and also as the inaugural Chief Diversity Officer for the Indiana CTSI. In 2024, Dr. Sotto was recruited to serve as the inaugural Associate Vice Chancellor for Faculty Development and Inclusive Excellence at the University of Pittsburgh Health Sciences, where she's also an Associate Professor of Medicine in the School of Medicine in the Division of Pulmonary Medicine. Her scholarship is truly remarkable. It is focused on equity and inclusive excellence. Her interests include faculty affairs, professional development, inclusive learning environments, organizational structures and leadership, and the intersection of health equity and research ethics. I think we're in for a real treat today. Please join me in welcoming Dr. Sotto to the podium for her Grand Rounds entitled Reclaiming the Mission of Academic Health Centers. Welcome.
Test. Well, that was a very nice introduction. Thank you very much for not only the invitation, but for being here today. You probably didn't know what was coming with this talk on reclaiming the mission of academic health centers. It is a thrill actually to be back home. I was in Puerto Rico, born and raised and stayed there for 20 years. Lived in Colorado for another 20. So I always say that my climate tolerance is between 32 and 100 degrees. Pittsburgh will be a test for us, and that just happened. So for those of you that thought that I was still in Indiana, surprise, I'm a vice chancellor at the University of Pittsburgh and have been there for 4 months. I want to share a little bit about my journey. And the reason why I do this, even though there was a fabulous introduction, is so you understand a little bit where I'm coming from in terms of that positionality and the reason for this talk. So as it was mentioned, again, all the degrees and the educational achievements, but I want to highlight a couple of places here. So I started as a PRA in Med-Onc and then moved to pulmonary in 2001. And I have come long ways now. I did 2 stints at CU, one in the 8th and Colorado campus, and then over here. In the middle of that, I got a little bit more degrees and went to University of Denver as research compliance officer. And the reason why I left that position was because there was a position open and for assistant vice provost for research. And I was told that I had all the qualifications, but I didn't have a doctorate degree. Okay. And that hurt really, really bad. So I actually thought, what's next, right? Because it seems that I have achieved, this position at University of Denver, what is there left to do? So looked back into academic medicine and ended up here as division administrator. It was a little bit less than a lateral move, but it was what I needed to do at the time. I say that for those staff here, that sometimes you have to go backwards in order to move forward, okay? And during my time at CU, I decided to do my doctorate because I knew exactly what I wanted to be when I grew up, even though I went to get my doctorate at 40 years old with 3 girls and a husband, working full-time here, okay? And that was the 80% that gave me joy, which was helping faculty and students of color at CU. The opportunity came up to go to Indiana University and do exactly what I wanted to do. And I enjoyed almost 10 years there, and it was fantastic. And now I am at Pittsburgh. So I cannot tell you anything about Pittsburgh because it has only been 3 months and we're still in boxes, okay? But I wanted to change the environment. I wanted to really relook at my mission and what motivated me. So in terms of disclosures, I have the usual. No conflict of interest. My opinions are my own. They do not represent University of Pittsburgh, and you will see in a second that it also does not represent Indiana University. But I like to add my own. I have biases like everybody else. I have privilege. My identities inform how I navigate the world. My biases will come through today. I hope you're ready for them. And if not, we will have a great conversation. And I also firmly believe in equity as a tool towards equality and education and health sciences. That's really what motivates me. So we're going to try to achieve 3 things today. We're going to build upon the current understanding that we have of the mission of academic medicine in the context of health equity, health education, and yes, DEI. And I'm going to summarize DEI, but you know that will be diversity, equity, and inclusion. If you want to add justice, accessibility, and belonging, that's fine with me, but you will see it in the slides as DEI. We will also talk a little bit how we can link inclusion to excellence, especially in all the stages and pillars of academic medicine. And then I will invite you to critique a little bit the structures and public policies that we have currently that are impacting health systems and health equity today. So let me start by this question. I'm also not a lecturer. I tell the students and faculty, I need energy, otherwise I get bored, as you all do. So let me ask, what is the mission of academic medicine? And I'll take 2 or 3 thoughts. Bueller, Anyone? You don't know what you're here for? To train physicians? Okay. Anything else? To what? To create leaders in academic medicine? Badish, did you say something? Who else said something? Oh, Bull. What did you say? New discovery. New discovery. Okay. I don't mind those. Those are good. I gotta tell you that my favorite definition of academic medicine, or what it is, comes from 1989. And it was stated by Schroeder et al. And I will share that with you. So Schroeder actually said, and I have to read it because I haven't memorized it, okay? But in order to have academic medicine, let me summarize it because it's kind of long. Academic medicine really is about more than clinical research and teaching pillars. So let me summarize it there. That there's a public responsibility and there's a social mission. And that was in 1989. And for many decades, we have forgotten that there's more to it than clinical research and education. During the pandemic and George Floyd's murder, we decided to take a look, my colleagues and I decided to take a look at all those institutional responses. I believe University of Colorado was included. And we collected about 100 of them, and they were very interesting. They were from higher education and academic medicine. And I don't need to tell you, more than they all had the same thing. What did they have? They declare racism as a public health threat. They talked about society. They talked about inequities. They talked about disparities. And only a handful of them actually said the words racism and murder. So it was clear that we needed to reclaim the mission of academic medicine if we had suddenly this momentum to tackle anti-racism in academic medicine and the health sciences. So I want to hold them, accountable for that. The other thing is that we're in 2024, that was in 2020, and 4 years later, either we're running out of energy and passion, or we are simply passive about what's happening around us. Health equity is serious, and it has been challenged through anti-DEI legislation, whether you want to admit it or not, whether you think DEI is bogus or not. There is certainly a misalignment between the vision, the values, and our mission. So let me bring you back to those values. By the age I see around here, you may not remember what was in your medical school or graduate application. But let me remind you. So during 2016 and 2024, I've been interviewing medical students and residents and have collected a few quotes. This one in particular is from an applicant to medical school. It says, "I have seen the value of compassionate and empathetic care. What healthcare providers do for patients can only be described as magic." How does that make you feel? Like a magician? Yeah. Here's for residency. Let me highlight two of them here. "I am seeking a residency program that supports my commitments to lifelong learning, humanistic care, and health equity work." And the other one is, "I share my patients' joys, yes, but also their hardships. I saw all too often people doing their best to get by, but being let down by inadequate support systems and limited healthcare access." How does that make you feel? Do you remember now why you went into medicine, into science? The themes that always come up is people want to help, right? The applicants and the candidates want to help. They believe in health equity. Many of them mention diverse patients. They talk about social determinants of health, especially as barriers. They share patient studies, stories, good or bad. They do so. But overall, it's for the good of the people. So a show of hands, how many of you went into medicine science for the good of the people? It looks like a lot of you. Whoever didn't raise their hand, I hope that it was because you were putting a chip in your mouth. Right? Okay. No one ever said, I want to make money. Maybe one candidate for surgery, but that was it. Okay. But in my opinion, and I want to highlight that this is in my opinion, remember what I said in my disclaimer, you cannot separate the social mission from health equity. This is what the social mission is, health equity. You're all about health. You went into this field to provide care for all patients. But in order to still provide care for all patients, you have to delve a little bit deeper. And that's where I want to just touch base historically. I have a whole class this, and I have summarized it in two big issues, right? At this point, you should be familiar with the Flexner report, right? It really set forward what we know as schools of medicine today, setting up accreditation, setting up structures for medical education training, et cetera. But it also harmed other medical schools because of this, which is not to say that it wasn't needed. A lot of medical schools closed in the United States, impacting more those schools that accepted Black medical students. And we are still trying to recuperate from that. In the unequal treatment report, again, something that I'm sure you are all familiar with, of course, the initial one highlighted these disparities in race, ethnicity, gender, et cetera, et cetera. But the newest report, have you read it? It's ending unequal treatment. And it says that we have made a lot of progress, but what's the but? There's a lot to do. And what they really spent their time doing was actually looking into strategies, looking into interventions, letting us know what worked, what didn't work, so we can actually apply it towards solving this issue of health equity. So again, in this unequal treatment report, in telling us that there's still work that we need to do for equal treatment and equal care, we need to reclaim the social mission of academic medicine. We stated in the paper, reclaiming the social mission will be a major step towards advancing health equity. This reclamation is required in order to improve the health and well-being of individuals and marginalized communities. Again, in my opinion, DEI initiatives drive health equity. And I'll tell you a little bit. If you want to think about the first DEI initiative, think about gender diversity. I consider this one of the first DEI initiatives. The minute that we allowed a woman, Dr. Elizabeth Blackwell, to attend School of Medicine in the United States and graduate. That was about inclusion. That was about equity. And that was about diversity. And we know that because in 2017, it was the first time that women reached 50% of matriculants in medical schools. And even more so, this is from 2024, May 2024. They check again the numbers about women physicians, and it had increased 97% in almost 20 years. Those are big numbers. Every university or academic center, I hope, I shouldn't say every, has a women in medicine and science group. Whether it's formalized, whether it's not, where it's just a few women in the division going to dinner, it still wins. And that was created to support women. It was created to advocate for things and benefits for women. And all that, again, is diversity, equity, and inclusion. I checked a little bit more on internal medicine because I figured I was here. And you can see that between 2004 and 2022, the number of women in internal medicine is now 40%. So it increased 10%. I'm going to ask you, do you know the specialties that saw the biggest growth, largest growth in women? Nobody? I thought because pulmonary and critical care is here, they were going to take some pride. But here are the two divisions. Critical care, the number of women increased 392% during that period. And for GI, 219%. The initiatives work. Hopefully you also remember seeing this article where it talked about Black men in medicine actually being or matriculating less than in 1978. That caused, oh my God, quite the effect in academic medicine, to the point that in addition to all those pathways and associations and communities that were already established, we bump it up to absolutely the highest levels. And for 2023, we had basically 1,000 or more than 1,000 Black men matriculating in medicine. You know what also happened in 1978? I didn't know this until recently. It was the first challenge to affirmative action from a white man trying to get into medical school. So academic medicine has not been in the sidelines of all of this. We also think about, this issue with respect to race, ethnicity, and gender, and not so much in all the other aspects that meet this diversity definition. So again, medical students with disabilities has been hovering at 3%. 1 in 5 patients declare a disability, and 1 in 33 physicians have actually indicated that they have a disability themselves. And every year, it's reported to the AAMC that between 1,000 and 1,500 medical students declare a disability. And a portion of these have been discovered during medical school. Again, I know every DEI discourse that you can probably, throw at me. But let me tell you that there's absolutely no reason why this should challenge excellence. This class of 2022-2023 had the highest GPA than in recent years, at 3.82. Let me remind you that we said that we added more than 1,000 Black medical students. So whoever says that you have to lower the standard is sadly mistaken. We also have diversity in the age. Kudos to the person, it's actually a woman who's 53 years old, attending medical school. This class had the highest hours of 15 million in community service. There was an increase in first gen, there was an increase in students with disabilities. So I firmly believe DEI operationalizes the academic medicine social mission of health equity. In a recent paper, this was actually maybe just last month, we tackled this, a critical look at racism in the clinical learning environment and the erasure of DEI efforts and what it actually does. So there is consensus amongst all health professionals and educators that racist systems are perpetuating disparities and inequities in healthcare. That racism impedes entering the field. But we also posted that reliance on morality is not enough for us to say, we're doing the right thing. We don't need to do more. That doesn't affect us. I'm a good person. I'm taking care of patients. It's not enough, okay? And in this talk, I am trying to the best of my abilities, separate morality from evidence. And I'm going to continue to provide you evidence, okay? We also have found that in recent years, we have really relied on student-driven activism to basically help us develop whole new curriculums. We have charged residents with developing their own health equity curriculum. We have done a lot of that, and that should not fall in the hands of students, not from an experiential perspective. This is great, but not abusing their interest in health equity and diversity. So let me share with you a few strategies that I believe actually help the goal of embedding DEI into every pillar, which is actually inclusive excellence. So if you ask me what inclusive excellence is, it's really taking into account equity and inclusion in every decision that is made. And it only takes for you to ask, what would this be like for some other group? And you can do that at the bedside, and you can do it when you're looking at quality numbers. You can do it at any point. We see this in data collection and analysis, especially because we're gathering and analyzing demographics. In community outreach and engagement, we see it because we're involving diverse communities, sometimes really low-income communities, rural health issues. At Pitt, we have 5 to 6 community engagement centers. They all have 25-year contract from University of Pittsburgh, commitment to those communities. And that is sustainability. That is health equity. And let me add one more, culturally responsive care, obviously training healthcare providers to better understand and address the unique needs of diverse patients. They can improve the patient-provider relationship and care quality. And you can see the other ones there in terms of targeted interventions, inclusive workforce, again, recruitment and retention, patient satisfaction, and the exercise of constant evaluation. That should say how do. So how do DEI and health equity initiatives contribute to the academic medicine? So I told you a little bit about the DEI aspect. So how that combined with health equity contributes to academic medicine. And once again, you probably can figure out some of this, of course, in the patient care. When you incorporate DEI into medical education, it assures that the future of healthcare providers are trained to recognize and address health disparities. This prepares them to provide culturally competent care and advocate for health equity. When we're talking about leadership development, DEI efforts can cultivate leadership skills among underrepresented groups, ensuring a pipeline of diverse, inclusive leaders in academic medicine, which again draws more underrepresented and historically marginalized groups, not only into academia, but looking into leadership positions. So both DEI and health equity are closely related. They're closely related in the equity focus. They're closely related in the structural drivers. Actually, I am moving on from calling in them social determinants to structural drivers of health. I invite you to do the same. We are actually related when we talk about the importance of representation, structural and cultural competencies, and policy development. So integrating DEI into health equity efforts enhances the effectiveness of initiatives aimed at improving health outcomes for all, especially marginalized communities. My 16-year-old actually asked me what that all meant. Because she was like, say it again, Mom. And I said, you know, the wheelchair curb in the street, it was created during after the ADA was signed to give, again, people with disabilities access, to give them the same opportunities for employment. And this was about mobility and transportation. Have you ever walked through a ramp instead of the stairs? You have. I've seen you. I've done it. So by creating something for a specific group to help them and elevate them, we have all taken advantage of the ramp. So inclusion also drives excellence and health equity, and inclusive excellence was introduced to higher education in 2005. And here's where I'm going to share some of the things that you already know, because the business case for DEI has been made over and over again. So again, we know diverse teams are more rigorous and thoughtful in their decision-making. More ethnically diverse executive teams are 33% more likely to outperform, and the benefits go on and on, okay? Even your favorite authors, or maybe they're my favorite authors, that's actually one of my leadership bookshelves. Adam Grant talks about diverse perspective, cognitive diversity, inclusivity, and collaboration with empirical evidence. Malcolm Gladwell talks about diversity and how it impacts society, innovation, and decision-making. When we're linking inclusion to excellence, again, we are talking about addressing health disparities and health inequities in our systems. So when you incorporate inclusion to excellence, you're actually tackling access to quality care. You're tackling the recruitment into clinical trials. You're ensuring healthcare access. And for research, is it key to have a diverse team? I think so. I could give you a whole list, because there's a whole list for research, but I figure you know this, okay? In terms of the education and curriculum, again, when you're linking inclusion to excellence, I just showed you the numbers of women, of Black men in medicine. It actually contributes to the diversification of providers to match the US population. And faculty diversification. I have to say that this is one of the good things many good things from Indiana. I was part of the medical Spanish program, which is not a medical Spanish elective. It's not a medical Spanish transition seminar. It's a 4-year longitudinal medical Spanish program. And we teach the same foundations of clinical practice in Spanish. And I can tell you, every year we have about 20 competitive medical students applying to this program. And more than 50% of them are not Latino and Hispanic. So the students are coming in recognizing the importance of their position when it comes to health equity, diversity, and inclusion. They know what's up. When you think about 1 to 4, I always tell people, the students that are coming in are at a 4. They know health equity. They know community engagement. They know what they should be learning. And our faculty are at a 1. That is not to say all faculty, okay? So for the last aspect here, I want us to think about critiquing and considering structures and policies that impact health education and health systems. So not too long ago, I was invited to chair a committee at Indiana University. And I said, what is it about? And they said, oh, it's an anti-racism committee. I said, like, okay. Then the charge came And it was to review policies and procedures at IU Indianapolis and 2 regional campuses. What policies and procedures? I asked. All of them, they said. It took 2 years, and I can tell you that we didn't even get to 10% of the policies and procedures. We looked at faculty, we looked at undergrad education, we looked at honors programs, we looked at graduate education, we looked at placement of TAs, placement of research assistants. We looked at campus police. And it was too scary, so we recommended that a consultant came in and dealt with that particular mess, okay? I can tell you also that the lesson learned, there was no racist policy, explicitly racist policy. It was the implementation and interpretation of that policy or procedure by a leader, by a staff that impacted diversity, equity, and inclusion at the institution. So that's why I spent extra time talking about the unintended consequences of good intentions. Not every policy is here to harm us, but we also need to question the policies that we have right now, if down the road they're actually impacting other populations. This is where I'm going to say, in my opinion, more than once. Everybody's familiar with the Supreme Court decision, I hope. It was about admissions in undergraduate and graduate education. And they determined that race shouldn't be used as an item to which qualify candidates. I wasn't all that worried because holistic review has been in higher education since the 1980s. So if you were still using just race for your admissions, that was just crazy. One of the things that it actually did as well was make academic medicine think twice. Because what is our place in that whole thing? Because we have funds from NIH. NIH is determining who is underrepresented in medicine. We have our LCME, ACGME. They have diversity, equity, inclusion requirements. So how does that impact us? Everybody went crazy. And if there's a lawyer in the room, I have to say, the disclaimer is also, I'm not a lawyer. But that healthcare leadership master's was in health policy law and ethics. And in my opinion, there was an overreach in academic medicine that counters the mission, the social mission, because it does not account for DEI as a contributor to health equity. There's the map, more than 80 anti-DEI legislations across the country. When did academic medicine go, uh-oh? Are you all familiar with the EDUCATE Act? Okay, let's talk about the EDUCATE Act, embracing anti-discrimination and biased curriculum and advancing truth in education. The bill would prohibit medical schools from receiving federal funding if they adopt policies and requirements related to DEI. They would also require accreditation associations and agencies to demonstrate that they do not require an institution or program to adopt DEI policies. So where does that leave health equity? in my opinion, there is a misrepresentation of DEI without considering its impact on health equity. The narrative that is out there is not talking about health equity. And as faculty in academic medicine, we have been quite passive. We're relying on AAMC, we're relying on AMA, on lobbyists to help us counter this type of legislation. But in our corners of academic medicine, we have been pretty quiet. I wrote this op-ed. I put the QR code because that's exactly where it takes you, op-ed. Nobody wanted to pick it up. I had one of the faculty at Indiana who publishes in New York Times, who read it and said, this is exactly what I would send. Nobody picked it up, okay? So it's just in a blog, but you can read it. I want to highlight actually one of the things that was there. It was about, about rural health. I don't just focus on race, ethnicity, gender, people with disabilities. Rural health is part of diversity, equity, and inclusion. Rural populations in this country have been marginalized and certainly are suffering from healthcare access, healthcare outcomes, et cetera, et cetera. My role in the CTSI was about community engagement, mostly with the rural populations in Indiana. And if you're familiar with the state of Indiana, there's really only 3 big cities that I call big cities. Everything else is farm. Okay? So rural health is also DEI. We have not included them in everything that we do. How many clinical trials are you going to Salida or Durango or whatever to do? Not many. We just stay in our circle here. The consequences of the anti-DEI legislation, however you feel about it, the consequences of even having the Educate Act in the Senate, what did I do? Emma. The consequences of this anti-DEI legislation in academic medicine and its mission can already be seen. In Indiana, Senate 202 was passed around February or March. And it had the usual stuff. You can't say DEI, blah, blah. But it went a little bit further. And this is what I mean with the overreaching. The Supreme Court didn't talk about tenure. They didn't talk about faculty promotions. But the state of Indiana actually chose, or the representatives chose to include that no professor, no faculty member was going to get tenure if they did DEI work. And those that have tenure will be reviewed every year by some secret commission. It's not a secret commission. They just haven't figured out where the commission is. They just threw this stuff out there. There were complaints, activists, protests, and it still passed. How did I end up in Pittsburgh? Many reasons. I needed to grow. It was a good opportunity. Da, 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 da. But I also consider myself an anti-DEI refugee deserter. I'm an associate professor of medicine with tenure. I am part of the 1% of Latinas associate professors in this country. And now you want to take away my tenure or review my tenure because I'm doing health equity work? Because for me, focusing on faculty of color, staff of color, students of color is health equity, and it is the mission of academic medicine. I said the Senate bill passed in 2002, Senate Bill 202 passed in February. We're receiving applications, and these are the consequences. It was reported IU School of Medicine sees a steep drop in students underrepresented in medicine. This is exactly what people said was going to happen. This is exactly what some may want to happen. Indiana University School of Medicine is the largest school of medicine in this country. It has between 360 and accept between 360 and 380 medical students every year. For the last 5 years, we have been growing that underrepresented medical student population. To what do you think? Throw a number. Throw 2 numbers at me. How much? 20%? Okay. Anybody else? 40%. Oops. Clearly, it's not 40%. You just blew my mind. It was 25%. I was there for 10 years. I'm not saying that I was responsible for all the medical students coming in, but I know that my work was contributing to medical students coming in, and residents, and faculty of color. Give me the number that you think was accepted or matriculated, I'm sorry, this year, this class. How much? 10? Okay. Anybody else? 8.8%. And that is not just infuriating to me, it's also infuriating to the white faculty, to the white administration. It's infuriating to everybody that has worked really hard. And now you just have 8 out of 100 students representing or being a member or deemed a member of a historically marginalized group. So how do we reclaim and perform our academic medicine mission? And I have to say, perform is not meant to be performative. We have too much of that. I meant it really as do it, okay? We have to mobilize for your patients, for your students, for your trainees, and your colleagues. And if you don't care about your colleagues, that's fine. But think about the patients. In the United States, the majority of low-income communities are served by academic medical centers. So what can you do as faculty? Follow the students. Student activism is fantastic. Maybe we should adopt some of the strategies that they have used. Disseminate the facts with evidence. We know what happened with COVID. Could we have been more passive in the communication? We know that it created mistrust and distrust, which is the talk tomorrow on pulmonary. Okay. You have to engage with patients, communities, and advocacy, and reclaim the social mission. I added this Congressional Academic Medicine Caucus because it was just grouped as a product of the introduction of the EDUCATE Act. You can all find out about this caucus. The senators needed to understand what is happening in academic medicine. And that's exactly what it says. So if you search for it, that is actually what is in the homepage. You know who's the co-chair of that caucus? The same person that introduced the Educate Act. To me, that's fantastic. That's how we bring people in to learn, to understand what we're about. So if you find yourself in this situation, I hope that if you gather anything from this talk, is that you say DEI contributes to health equity, period. And if you're in a state, again, I'm not familiar with what Colorado is doing, but how do you say DEI without saying DEI? It is health equity. You're talking about accessibility. You're talking about community engagement. You're talking about health access, disparities, inequities. Lived experiences is highlighted because the Supreme Court did give us something. They said they cannot preclude an applicant from writing in their personal statement about their lived experiences. We still know how to find the students. We still know how to find the residents. It's in that lived experience. So my closing statement, which now seems a little pretentious, but is above MLK and Baldwin. Academic medicine has a social mission. Medicine is about health equity, and you cannot accomplish health equity unless you are informed by DEI. In my opinion. And I'll leave it there. I'm done.
Thank you, Dr. Sotto. That was very inspiring and moving. Open for questions from the audience? For those online as well? Oh, we have one there. Jeff, will get you a microphone because people can't hear online. Thanks.
Yeah, question was about reflections on the University of Michigan experience for DEI over the last 10 years, which I haven't read in completely, but have seen bits and pieces of it.
I will tell you, just to share the pieces of it. The summary of that report is that University of Michigan have spent dollars, millions of dollars in DEI initiatives and bringing personnel in and all the things that made DEI Michigan the envy for those of us that do equity work. But money doesn't say that things are done correctly. So I don't know all the details about how the machinery in Michigan worked, but I did read the Times article and I was devastated because of what it communicates, right? Because I think it was upwards of $60-something million spent in DEI. My only opinion on that is that, again, we are not doing holistic review well. I don't know. But I also have another one. How many Black and brown folks you see in diversity positions? How many Black and brown folks are the only ones in the committee? How many of Black and brown folks have been told this is the position, this is the leadership position? And how many of them have actually been trained on how to do diversity, equity, and inclusion? Most of individuals, and I travel WNC and GDI, have not gone through a doctorate degree in inclusive excellence, they're fantastic because they're passionate, They have their own lived experiences that inform. So maybe Michigan was not doing it right, even though they still show increase, but certainly it wasn't up to the amount of the millions of dollars that they spent.
Thank you so much for that wonderful talk. We recently asked our residents if they'd be interested in mentoring URIM applicants, and the answer was a resounding yes. Besides including their lived experiences in their personal statement, are there any other recommendations you have specifically for coaching them through the application process?
Oh, that's really great. The short answer is no. Because I'm focused on the personal statement. I'm assuming if you're sending it for review, the MCAT scores was fine with you, the letters of, recommendation are all the same. So I really myself focus in the lived experiences aspect of the personal statement. That's what for sure I read. And actually I'm gonna work with the Pittsburgh folks to identify where all that is in a personal statement. The personal statement talks about community engagement, where they volunteer. It talks about what fraternity, sorority, what group they're part of. Most of the time it says where they grew up, what they have seen. All those parts are really coming through the personal statement. So unfortunately, I don't have other answers than rely, because that's what the Supreme Court let us do, right? The lived experiences. If everything else is stripped out of the application.
Hi.
Let me say this. Can I say this?
Yes, you can say this.
Miss Etta Ward is here. She's from Indiana University, or I met her at Indiana University. And she's a fellow deserter.
Yes, I
Go
am,
ahead.
as of March, after 23 years. So I want about the mentoring. There are great resources out there that'll help you with good, culturally responsive mentoring practices, a lot of which our speaker here advocated for the School of Medicine as a intervention to help keep people in place and safe within the mentoring experiences. They can be harmful. So understanding that within the practices is key. What I wanted to ask you was, you talked about mobilizing. And I know within the Black and Brown communities, there's a lot of circles coming together to be strengthening and strength for each other. But how do we bring in the majority community to help with this activism when there are issues of lack of psychological safety to be able to do this work? We can use other words that mask and represent diversity, equity, and inclusion, but when it comes down to it, when you're advocating for programs and interventions for these populations, there are some consequences that come with that. How do we keep folks in this process of activism? Our students do it well, as you say, but faculty and staff fear the consequences. How have you helped with that?
That is a great question, Etta. I'm going to answer in two parts. The first one, that again, the mission is health equity. So for those of us that are in the health sciences, we can continue doing the work. You have seen strategies of just, changing the name, the titles, the funding, source for these efforts. But the work for us is still there. It's still health equity. In terms of the damage that can come from standing up for this, faculty and staff are very vulnerable. So I charge those with tenure to take a little bit of the burden. I ask all of you who are interested in health equity, because it's not just Black and brown folks, to stand up for these DEI initiatives that benefit health equity. I think we need to come together and certainly not rely on the 1% associate professor with tenure, Latina, at the institution. That includes white women. We saw you were beneficiaries of DEI initiatives. That includes white men and the new generation. It's all for this. So, and the leaders. A leader that has not attended a culturally relevant mentoring program or not a single DEI or health equity professional development sends a message. Sends a bigger message than the person that attended. If you're not there as a leader, you're sending a message. Those are some of the ideas, Etta.
Dr. Sotto, thank you. We are at time, so I want to thank you again for a really inspiring and thought-provoking talk, and look forward to continuing the discussions. Thanks very much.
Thank you for bringing me home.